Bismillahirrahmanirrahim. In this third video of site-specific regeneration, the regeneration of the kidney tissue is discussed. These are the references for this video. The kidney has got a limited regenerative capacity. After nephrectomy, that is removal of one kidney, the remaining kidney undergoes compensatory hypertrophy. That means existing cells enlarge. If the extracellular matrix and basement membrane remain intact, the damaged tubular epithelial cell can regenerate. In most renal diseases, the matrix disruption lead to scarring and incomplete regeneration. The cortical tubules have got better regenerative ability than medullary tubules, and podocytes, that are the specialized glomerular cells, may regenerate or hypertrophy in some conditions like diabetes or nephropathy, particularly after therapeutic intervention. Endogenous multipotent tubular cells, not the bone marrow derived cells, are primarily responsible for tubular repair. So the renal tubular epithelium are lined by cuboidal epithelial cells, and they turnover, there is epithelial turnover, and they shed into the urine. They continuously shed and divide. So there can be two responses to the injury. One is when the basement membrane is intact, and another when there is tubular hexes and the basement membrane is not intact. So in surviving tubular cell, they flatten and they migrate across the basement membrane. There is active microcyst take place, and cell redifferentiated to cuboidal epithelium once they reach at the site of the damage, and the tubular architecture and function normalize within 3 to 4 weeks. The another mechanism is tubular hexes, where the basement membrane is ruptured. Here the repair is more complicated. Fibroblasts proliferate and accumulation of the extracellular matrix takes place. The lumen of the tubule, it collapses. Some tubule regenerate, but other become fibrotic. This leads to focal nephron loss and potential decline in kidney function. So this can be visualized by a pipeline system that can be used for tubule. These pipeline system of tubule is sitting on a concrete base, that is basement membrane. When there is surface damage, the workers, that are epithelial cell, they reseal the cracks quickly. If the foundation cracks, as happens in tubular hexes, the external repair crew, that are fibroblasts, they build the patches or scar tissue. This scar tissue formation narrows the pipeline, and some section of these pipeline work again, while some become blocked permanently. So this will result in focal losses of functional nephrons. So the cortical tissue or cortical tubule that are damaged, they may be regenerated by simple division. There are no distinct reserve or stem cells present, and if the basement membrane is intact, they survive by flattening of the tubular cell. They migrate, divide, and then redifferentiate into the tubular cells, and full repair occur within 3 to 4 weeks. If there is tubular hexes or basement membrane rupture, the fibrosis develops, extracellular matrix accumulates, there is luminal collapse and focal loss of the nephron occur. While in medullary tissue there is extensive necrosis that is common, and tubule plus interstitium and blood vessels, they are uh, necrosed. The necrotic debris sloughs into the urine and there is limited epithelial proliferation. There is healing mostly by fibrosis and there is internal urinary obstruction. There is no regeneration. While in glomeruli, they do not regenerate directly. Glomerular necrosis heals with scarring. Mesangial cells that are related to smooth muscles, they have got limited regenerative potential. Podocyte progenitor cells or that are in the Bowman's capsule, they may help replace lost podocyte after nephrectomy. Uh, the remaining glomeruli undergo hypertrophy and hyperplasia. So this concept of the regeneration in the kidney can be visualized as a plumbing network that is composed of tubule that is equivalent to pipes. Then there are filtering units that are glomeruli that are fine filtration chambers, and this is supported by a supporting scaffolding that is basement membrane or pipeline foundation. So minor pipelines leak, so there is quick repair of these minor pipeline. There is epithelial migration and division. The foundation crack when occur, they are partially rebuilt with patches of the scar, that is fibrosis. If there is breakdown of the filter or filter chambers, they are collapsed or there is scar formation as happens in glomeruli. The control center expands surviving unit after nephrectomy. This is a picture of end-stage kidney disease, chronic kidney disease with scarring, also called end-stage renal disease or ESRD or granular contracted kidney. Here the key features of this picture are contracted irregular nodular surface. There is diffuse granular lumpy appearance, smooth area is not there. So there is loss of smooth cortical surface that has been replaced by diffuse granular lumpy surface. The size is also shrunken. The overall size is decreased, reflecting a chronic atrophic process. It is firm in consistency, and this firmness is attributed to the fibrosis that occurs inside this kidney. As we will see later in histologic picture, most of the architecture is lost. Microscopic architecture as well as the gross architecture is lost. The differentiation between the cortex and medullary area are lost, and there can be presence of multiple broad scars or fibrous tissue are present. These fibrous tissue contract over time, leading to thinning of the cortices and irregular depression across the surface. This appearance is typically seen in hypertensive nephrosclerosis, long-standing hypertension, chronic glomerulonephritis, late stages of diabetic nephropathy, chronic pyelonephritis, vascular disease of the kidney. So there is one chronic injurious process that lead to glomerular sclerosis, tubular atrophy, and interstitial fibrosis. So there is loss of nephron that results in shrinking of the kidney and scarring occurs. So that results in a contracted granular kidney, as you can see in this picture. So this is a kidney tissue that is stained by hematoxylin and eosin stain, and there are many glomeruli that are here, and they are totally hyalinized and sclerosed. So this is global glomerulosclerosis. The glomerular tufts are shrunken, and they are replaced by pink homogeneous material that is acellular, and it is collagen plus extracellular matrix. The tubulointerstitial compartment is showing the aggregates of these bluish cells. These are dense lymphocytic infiltrate that are present in this tubulointerstitial compartment. The tubular atrophy is also visible. The tubules are small with thickened basement membrane and flattened epithelial lining. Some of the tubule they are showing pinkish material inside, but this is not a prominent feature. This is usually termed as thyroidization, but this is not a prominent feature over in this specific field. The arterioles in this section they are thickened. There is prominent arterial hyalinization and thickening of the vessel wall. That is the classical feature of hypertensive or diabetic nephropathy. So this is a typical case of chronic glomerulonephritis or end-stage kidney disease with the global glomerulosclerosis, tubular atrophy, interstitial fibrosis, and presence of chronic inflammatory infiltrate with changes in the vessel wall. This these features or these morphologic features are seen in long-standing hypertension, diabetes mellitus, chronic glomerulonephritis, and other progressive nephropathies. Thank you for watching this video. If you have any question, please write in the comment box.